Well, hello everyone, and welcome to the GHP Brown Bag. My name is Olivia Mulvey. I am a fellowship manager at the Harvard Global Health Institute, and I work closely with Dr. Anna Langer, who's the director of the Women in Health Initiative. Many of you by now may be familiar with our lead fellowship. 4 of the 5 fellows have given Brown Bag presentations through this seminar over the past few months. And I will just quickly add that the LEAD Fellowship is a leadership advancement opportunity that is co-led by HGHI, the Harvard Global Health Institute, and the Women in Health Initiative at the HSPH. So today's seminar is quite exciting and unique in that it will feature all 5 of our 2021 LEAD Fellows, and it will be moderated by Professor Jesse Bump. Professor Bump is the Executive Director of the Takemi Fellowship and lecturer on global health policy. Professor Bump and the LEAD Fellows have been working together closely to develop this seminar titled Decolonizing Global Health, the Role of Women Leaders. I will now turn it over to Professor Bump to get us started. Thank you all so much.
Thank you, Olivia. Thank you very much. Thank you to everyone who's joined us. This is a delight to see so many of you. And it's really my honor and pleasure. So I'll begin by thanking Anna and the fellows for asking me to moderate. And I'll offer a few remarks and then we'll hear from the fellows themselves. So today's seminar on the decolonization of global health and the role of women leaders is a reflection of a broadly felt and deeply significant movement in global health to examine its colonial roots. Not to simplify what colonialism is, but to encapsulate many of its dimensions, I'd offer you a definition that I use in my research and teaching, which is that colonialism can be understood as the state-sponsored construction of non-merit inequalities that extract from one group to benefit another. There are many aspects of this that are pervasive in our modern world. One of them is the extremely unequal and unfair outcomes and distributions of health and wealth around the world. Another is the concentration of power and other resources in the former imperial capitals and their institutions in the colonial metropoles and their institutions. That includes Harvard, where we are now. It includes other august schools in global health. And our commitment to undo or counter these influences includes making space for discussions like this one, where we can all examine our role in the game, where we can question the primacy of outsider knowledge and where we can advance the voices of community members as we try to redistribute these non-merit and unfairly earned inequalities. So in today's presentation, we're recognizing 2 different kinds of effort to do that. One is that we try to democratize access to our institutions by bringing other people in to benefit from the accumulated resources and to build capacity. The other is that when we can, we cede our spaces to them so that they can tell their own stories. So as we turn to our 5 fellows today, all 5 lead fellows, we have Preethi John from India, we have Alice Kayongo, Julieta Kavetuna, Marley Clarkson, and Bridget Malewezi, all from Africa. So they will tell us their stories and they will help illuminate how the practice of colonial influences, how the practice of colonial patterns are shaping unfairly their opportunities and their opportunities to advance health for their people. So thank you very much. Preethi will get us going and I turn the floor over to her.
Thank you very much. This is an extremely important topic. And at the outset, good morning, good afternoon, good evening, everyone. I'm Preethi John, a Harvard Lead Fellow, a healthcare management professional with particular focus of work in human resources and healthcare management based out of India. Working in the field of academics as a women leader for the last several years, one of my interests has been to look at curriculum. And when I reflect on the kind of experiences I or several of my colleagues or my students go through in how they have used the healthcare system, what I realize is the difference between the experience one has and what you actually study. And just to illustrate, I will just share one example. So for example, when we are pregnant and a woman is about to give birth in India, depending on the cultural context, there are a lot of indigenous practices that take place. But when we go into the institutional care for our delivery, the indigenous practices that are quite the norm in most families either are kind of discounted or dismissed. Now, to put a scope to this, we look at what did the legacy of colonialization leave us with? And I think first of one, the indigenous systems kind of regressed and the allopathic medical system became central. And as a result of this process, the voice of the community, or what is healing, the context of healing, the definition of healing, largely got reshaped. And the people for whom healthcare is being delivered, their voices were not part of that decision making. It also meant several of the preventive healthcare practices that were happening disappeared, while a new set of preventive health practices had to come up. We also know that despite the linguistic diversity that is there, English became the main language. And this kind of shaped the healthcare, the curriculum. So at this point, I just want to leave a few questions before I hand over. That is, how do we now shape this particular healthcare curriculum, which has definitely spawned a set of healthcare professionals who are literally going all over the world? But how can we overcome the fact that they have not been embedded with sensitivity to the humanities, to linguistics, to compassionate healthcare? Or how do we change from a professional, in one sense, arrogance of being in a healthcare or a medical field to a cultural sensitivity or a professional humility? How do we now change all this? Because the topic itself is not an important topic or really being talked about in India. Whereas there is a lot more conversation about this in other places. So at the outset, I'd just like to leave these points to you. Thank you.
Thank you for those. Thank you for those, Preethi. Next, we have Alice.
Thank you so much, Professor Bump. My name is Alice Kayongo. I am a public health practitioner, a human rights advocate, and a Harvard Lead Fellow. I do work currently with Waki Health as a senior policy advisor. Waki Health is an Africa region-based advocacy organization working to champion health for all. I would like to build on what Preethi has said with regard to, this entire concept of decolonizing global health. And I want to note that this is a very timely and important debate, also very relevant in this point in time, as we all can imagine. And I want to start off by saying that it is important in the sense that it would be good for us to start off with systems change. Systems, and when I talk about systems, I am referring to systems that have perpetuated colonialism, systems that have perpetuated that kind of behavior. And for us to be able to change such systems, it requires a lot of action locally and globally. Action that will not see a class that is referred to as another class in many parts of this world, specifically in my region in Africa. I would like, to see a system or systems where we act locally and globally to see to it that we do not have divisive language that puts a notion of us and them and basically separates us in one way or another. From an African perspective, it's also important to note that for us to be able to decolonize global health, we must think critically about the component of decoloniality. Decoloniality in the sense that many of our values, many of our cultures, our beliefs, our traditions have been eroded by colonialism. You find that a cadre in Africa, many parts of Africa, the community health workforce, for example, is since time immemorial, community health workers in Africa were seen as, the first level of the health workforce that you get in touch with. They do a lot of work around preventive care, very less about curative, but nevertheless, we saw over the years that the local solutions that they were involved in actually yielded us quite a lot. But unfortunately, with colonialism, we see that a lot of the agency, a lot of creativity of the community health workforce, for example, has been eroded over the years. And it's no wonder that today you find that many community health workers are more of passive participants waiting for solutions to be imposed on them from the West and thinking less about our local solutions. It's hard for us to think about decolonizing global health if we are going to devalue local solutions. And it's important for us to actually underscore the fact that local solutions are very possible to solve problems at both local and global levels. I'll give you an example in my country, Uganda, just, with COVID, for example. Africa in general is one of the regions that has had the least number of vaccinations. In Uganda alone, as of yesterday, we were standing at 39% of the population having been vaccinated, fully vaccinated against COVID. However, we have also seen that our region has been least affected by COVID. And in Uganda, for example, we have been least affected. And you can't tell me for sure that what has reversed the COVID response in Uganda has been mainly because of vaccination or because of testing. I think a lot of it has been, if there is much that has been done, I think the solutions have been at local level. And at this point, if we are to decolonize global health, then we need to look at the local solutions and find out how can these local solutions actually be able to give us an answer at the local level, but also at global level. We have seen herbal medicine working out very well in many parts of this region, the Africa region, and all is going on pretty much well. So it's not only science. And if there was humility in this world, I would imagine that it is now time that the West, maybe universities in the West, can get up and invest in research on what is it that has worked in Africa, that has helped the response, the COVID response in Africa take the trajectory that it has taken. Of course, there are pockets in the region that have really been affected heavily, but on the overall, the region has not been as badly affected as many parts of the world. And I would just want to conclude by noting that, even when you see a cadre or a group of health workers, such as community health workers, giving them the agency, giving them the room and space to be able to thrive is one that would actually yield, in a way we would be able to see that, yes, we are now, getting on the journey to decolonizing global health. So I will end here and hand over to you, Prof. Jesse. Thank you.
Thank you, Alex. That was tremendous. Excellent job. Next, we'll turn to Mareli.
Thanks so much, Prof. Jesse. So I am Marley Classens. I'm an associate research professor at the University of Namibia. I'm a medical doctor. I'm an African research leader, and I'm also a Harvard Lead Fellow. I'm also a mother of 3. My research focuses on tuberculosis, HIV, and COVID within marginalized societies in Southern Africa. And I also feel very strongly about engaging young girls and women to make their way into the STEM fields. So I'm going to latch onto what Alice has said about research in Africa, since I'm primarily a researcher and that's where most of my experience is. And I want to start by giving 3 examples of my experience of colonialism in research in Namibia. So the first one is, a while ago, I looked at publications coming from Namibia in infectious diseases, specifically with regards to clinical trials within the last 10 years. We only had 8 such publications from Namibia, which was very little in comparison with the rest of the other Southern African countries. So number one, we have to do capacity building, and we realize that. And that's one of the reasons why I work at the university. But also when I looked in a little bit more depth, I could see that none of the first and the last authors were Namibian. And for me, that was kind of an indicator of not exactly the way that the research was done, because it's a very superficial indicator in a sense, but in a way, for me, it was an opportunity lost to get some young Namibian researchers having their own publications, because there were Namibians working on these projects. Something similar was published recently in the journal Nature in September last year, where they also reported on underrepresentation from the global south. This was more specific to articles with regards to development. So it's not just in health, but also in other spheres of science that we see these kinds of things happening. The second thing that I wanted to mention was travel to scientific conferences, because as a researcher, that's one place where we can network and showcase what we've done. And obviously in the last 2 years, it has been extremely difficult for everybody to travel, as we all know. But I think for people from the global south as such, and specifically from Africa, it's been even more difficult to travel. And I can mention 2 examples of these. So the end of last year in October, I was invited to go to the World Health Summit. And I literally could not go because I had the wrong vaccine. Not because I wasn't vaccinated, because I got the wrong vaccine. But that was the only vaccine that was available in Namibia for me. So I was kind of in a conundrum, because I really wanted to go to this summit to go and speak specifically about research collaborations, almost the same thing that I'm talking about now. Luckily, in the end, through a few nefarious ways, I got additional vaccine, the Johnson & Johnson vaccine, and I could actually go. But that's not really the way that one wants to go. One wants to go in the right way, and one wants to be able to showcase your work in the right way as well. So that was the one example. And the other example was from another organization that I'm a member of, which is the Global Young Academy. And for every single year, there's 200 members in this academy. We were supposed to have our annual meeting this year in July. It was supposed to be a face-to-face meeting. And in November last year, when the committee sat for planning this meeting, I was on this committee. We realized that if we have a face-to-face meeting, basically all of the Africans apart from one, and there are 43 Africans out of 200 members, would not be able to join, also because we had the wrong vaccines. Again, not because we didn't have vaccines, because we had the wrong vaccines according to the country where the annual general meeting was supposed to be. So that, in a sense, is also for me showcasing what is, unjust at the moment in scientific travel. The last thing that I wanted to mention here, specifically with regards to research in the global south, is the hidden costs that we sometimes forget about. And there was an interesting blog post by the London School of Economics just a while back, and they specifically highlighted a few things. So number one, if we want to study from the global south in a similar place where our colleagues from the global north are studying, we have to think about exchange rates. It's extremely expensive for us to get exactly the same education as our colleagues from the north. So immediately we're not on par, because we can't get exactly the same education unless we go with a scholarship. The second thing that I want to mention under hidden costs is passport privilege. So if I want to travel anywhere in the world, I have to get a visa. A visa costs money, it takes time, it takes a lot of effort. My husband is a German citizen, he can go anywhere with his German passport. Obviously causes a lot of ructions in our marriage as well. But just, it's a practical example of what one has to go through. If I want to attend 3 conferences in 3 different places a year, and 3 are not that many, I have to get 3 different visas every single time. And there are lots of things in place that makes it really difficult to get a visa. For instance, just for the 5 of us, our 5 fellows now coming to Harvard in May, each one of us has a story to tell about our visa application. And it's just, I think, not fair, basically. The last thing that I wanted to mention under hidden costs is travel allowances. So for instance, if I take my own university, the University of Namibia, we cannot travel anywhere, even as an employee of the university, if we don't get external funding for that travel. So basically our university does not have travel money allocated for travel for its own employees. So what does that mean for me? I have, for every single research application that I do, I have to have a specific line item in my budget saying, this is for travel. I have to specify what it's for, where I want to go, how much it is, how many days I'm going to go there. And I can just mention one more thing. I have to be so specific because all of these details go into the contractual agreement with the funder. And if I just go one step off of the contractual agreement, then I have to motivate. So I don't see any autonomy in that either. So it's really difficult for us from the global south, taking all of these examples into account. I think we're going to come back a little bit later on ways to mitigate these kinds of things. But I think for me, primarily, it's really important that our colleagues from the global north become more aware. I know many of our colleagues in the global north are already aware of these challenges that we face basically every day. But I think awareness for me is one of the first steps, in the right direction. Let's become aware. The people from the global south, researchers, other healthcare workers, we don't always want to say, what, it's really difficult for us. Sometimes we just want the people from the global north to ask us, how can we help you? We know that you have challenges that we don't have to face. So I'm going to leave it there because we're going to come back to some other mitigating factors as well.
Thank you, Marley. I hope that those of our audience are starting to understand more of the vast number and many layers of the inequalities that we're talking about. Next, we will turn to Julieta.
Yes, thank you very much, Professor Baum, and my colleagues and everybody that is in the audience. I'm Julieta Kavetuna. I'm from Namibia. I'm currently sitting as a parliamentarian. I have been a deputy minister in 2 different ministries. I'm a mental health specialist and also a registered nurse by training. So that's me. I'm speaking today about the issues, the balance between the donor funding and the policy preferences in the global south. So just to give a background of where we are coming from with funding and the ideas around our policy preferences and also the designs of our programs to give better health to all Africans and in our communities to uplift the standards of our people in terms of health. African leaders in terms of ministers and head of states representing 1.2 billion people who are residents in the African continent on various platforms have been discussing about the ideal healthcare system, how they want to fund it, and also how they want to see the outcome that is coming from whatever they have decided. I will just highlight 3 very important gatherings or outcomes from the gatherings that have been discussed at various years and also during different times. The Bamako conference in 1987 have resolved that strategies that to create a sustainable drug component in the African continent. That means that they have been discussing on how they can produce drugs. That was actually the resolution of that conference, that African leaders decided that we need to put a plant that will produce drugs for Africa and supply for the Africans. In 1989, the Abuja Declaration came up with a formula where they have discussed that every country have, at least from their domestic financing, have to take a chunk of 15% and allocate it to health. And unfortunately to date, I just have been reviewing some data during the last week, and we realized that only 8 countries are on track. The other 46 are still struggling to reach even 6%. Then in 2008, the Ouagadougou Declaration that have declared that primary healthcare and healthcare systems should have a very should be handled and designed in a way that it have a better impact in terms of giving better health to Namibia, because to Africa, because they realized that prevention is better than cure, and that was actually the theme of that specific conference. Identifying 9 critical ideas, or which is ideal for them to reach those goals. It starts from the leadership of health in terms of governance in health, the human resource for health in Africa, and basically the partnership for health development. And in the partnership, that is what I'm coming to, because we are talking about the funding from donors, where unfortunately or fortunately, the United States of America is the biggest funder of most health programs in Africa across the continent. But what it's looking is that who designed the programs that's supposed to be funded? Is it according to all these 3 declarations that I have been mentioning, or is it coming a package that you have to take or not take? I just also, through the research, I have also seen that the executive director of African, the World Health Organization Africa region some years ago have said that a 15% for an elephant is not a 15% for a chicken. So that is actually that it tells you that the one shoe fits approach, a fits-all approach, will not deliver the desired results when we are going in models that are already packaged and also just deliver at our doorstep, that steps that you are going to do A, B, C, D, or you are going to do A, B, C, D. So the other issue that we need to question is the sustainability of programs that are funded. After the funding, who is taking care of that? Because we have our own priority as a continent. And when funds are coming for specific and after for specific program, and after that program, the funding have ended, where do we lose? Where do we leave those programs? Are we not losing the gains that we have attained during the course of 5 years during the funding, and go back to square one, or even in a worse situation? And what level of partnership is it? Is it always that the giver have to talk, or is there an influence from the receiver? That is actually questions that are coming up in our discussion, in this discussion that I have decided to raise in order for us to digest the issue, the balance that we can create between the funder and the receiver. How are we going to ensure that there is partnership that is impacting the continent, and at the end of the day impacting every citizen of the continent, when we are putting forth what is needed and what the government priorities are? We are not disputing the fact that when the CDC come with funds for typical losers or for malaria, it's not important. But what is it? What is the part that the government is bringing to say that no, for now we have actually at least addressed the issue of malaria? Can we look at HIV or something like that? So it's very important that we have to discuss the issue of funding in terms of promoting that partnership, rather than just receiving and going ahead and thinking that we have received money, but at the end of the day the gains are lost when the money is not it's not available any longer. So that's my first round, and I think when we come back, we can talk more with questions. We can discuss better and in depth on what we are saying. Thank you very much, Professor.
Thank you, Julieta. I really appreciate your insight into these issues, and it's particularly important that you're raising these systematic and structural dimensions of inequality, questioning the locus of power, and then explaining the implications of having it in faraway places. So thank you for that. Now let's turn to Bridget.
Thank you, everyone. And I'm Bridget Malewezi. I'm a medical doctor, public health specialist, activist and columnist as well. I'm currently the Vice President of Women in Global Health Malawi chapter, and also a task force chair for the establishment of the Women Doctors Association here in Malawi. As you can hear, I'm really passionate about women's leadership and participation, and also children's health. So that's something that I'm really engaged in currently, and obviously I'm also a Harvard Lead Fellow. So I wanted to round off sort of the conversation. As you saw from the poster, it was really discussing decolonizing global health and the role of women leaders. And I wanted to start off with putting us the perspective of what is the status quo now. And I found this amazing statistic, which just shows what the reality of women in this colonial structures that we've started talking about. And it was from the Global Health 50/50 report. And that one was exploring the boards of the governing boards for global health. They looked at 146 global health institutions sort of driving the agenda of global health in our world. And they looked at the 2014 board members in these governing institutions. And the percentage, maybe I'd even allow you to try and guess what percentage of women from low-income countries were part of these boards. You can put it in the chat if you want to guess what the number is, but the percentage of women from low-income countries was 1%. 1% of those boards that are making decisions about what is happening in global health, and especially was women. So this is just the stark reality of what's happening on the ground right now, is that we have boards that are making decisions primarily actually targeting women in these countries, low-income countries. We're thinking about women's health and children's health, which involves women. We know that women, for example, encompass 70% of the workforce, and yet the boards that are running these institutions only have 1% of women from these kind of countries. And that begs the question, are there no women leaders in these institutions, in the low-income countries? And I think that's really the reality of what colonization has brought on board, in that we have a dimension or an image that women in low-income countries are not leaders, that they've always been weak, that they've never really contributed, and they need to be empowered. And I'm not against empowerment measures. I think that there are some structures that exist that require empowerment of women in low-income countries. But when you look at what colonialism has done to our systems, and you realize that there were women leaders in our institutions, there were chiefs, there were mediums, and there were some structures. For example, if we look at the leaders in institutions, you would realize that there were women who, that gender was not often a factor, that women were as able to, for example, get spiritual gifts for healing as much as men do. There was no gendered aspect, and there were leaders. There was no aspect where, for example, you would say only women go to the female or only men go to the male healer, for example. That healing was an ancestral gift, and whoever the ancestors decided to bestow their gift upon, whether it was male or female, that they were a leader in their institutions. And we had social structures, for example, like traditional birth attendants, who were, well, when we're looking at health, who were able to provide care and were well respected in their institution, in their areas. So when you look at now that we are talking about their only 1% of women from these countries, from our countries, represented in these organizations, you do have to wonder, is it really that we don't have leaders, or is it that the definition of leadership has changed? Is it because of language barriers? Is it because the definition of what a leader should be like has changed, and therefore limits where women can fit in? I do understand, and I think that that percentage obviously shows there's obviously even a stark contrast, because the majority of these boards are heavily vested in people from high income countries. So for example, in these boards that we're talking about, for example, there was only 25% of those boards had any of the members were actually from low income countries. And then that's where the 1% only comes from as women. And so I think that there is a lot of conversations around what does women leadership look like, and what does that feel like, and how do we get meaningful participation? Because most of us, even as we get on this call, are probably women leaders or involved with women leaders, but are we making the decisions? Are we holding the power? And often that is not often the case. And I think that's the intersection that we're dealing with now, is that not only is there colonial structures, but also obviously the gendered factors that are limiting the role of women in driving this change. And so all of this has dismantled social structures that had existed that probably allowed women to participate more, both in their local structures, but definitely on a global scale. And I look at that in terms of how that impacts downstream in how we implement our programs, how if the voice of the women from the low income countries is not at that biggest of decision-making tables, I think as sort of Alice and others have already implied, that if we're not at the table to talk about our experiences, our cultures, our who we are as women, and certainly as people from the global South, how are these decisions really reflecting our needs and our demands and the real lived experiences? And we see that in some of the decisions that are made. I know, and I think I shared this, that in the Malawian context, for example, I started talking about the traditional birth attendants. They are now currently banned in this country. And these are structures that have existed before. Obviously, we had a problem with maternal mortality, and this was a decision made that the traditional birth attendants were limiting referral systems to the sort of Western and health system. But what is always often surprising is that women continue to go to the same traditional birth attendants that are banned. Why is that? It means there is a trust there. There is a culture that people believe in that, and that even though we are saying the hospital is better, women still go to these traditional birth attendants. Therefore, these structures should not only be diminished, or maybe looking at how we work with these structures and women in their role, and really exploring how women in wherever we are should be involved, and really thinking about taking us on board and taking on these measures. I know that we'll come back around and discussing how we all can get involved in the mitigating and other factors, but I thought that was an important part as we started to think about, okay, there's colonial structures, but then what is the role of women, and how are women experiencing colonial structures right now? Thank you.
Thank you, Bridget. I think it's really important to connect these dots to show how the legacies of the past are shaping the present, and to illuminate how what was once a contest for cultural and economic supremacy under colonialism is still dictating many of the patterns and causing division between the outside style of medicine, which could have some advantages, with what people want, which have many strengths. So thank you very much for that. Now, I'm going to invite the fellows to talk a little bit more about what some solutions could be and what some specific examples might be. So Julieta, would you like to begin on that?
Sorry. Yeah, thank you very much, Professor. I think the basic formula that we can be able to use in order to address the issue of funding is that every country is having a strategic plan on how they want to take their health from point A to B. And it is very important that the donors, rather than coming with programs that are fully packaged, they consult with the country on what program they have to address. I know there is interest in some specific diseases, but it doesn't help too much when you come and just do that part, and then after that the funds finish and the country go back to square one. I think it's very, very important that we should be able to address this issue by making sure that we create that balance of coming to a country and giving some funds, but do a specific program that will actually impact and also alleviate some of the systems of the diseases that are a problem in that country. I think that is actually what I would like to propose as a starter.
Thank you. Thank you. And an excellent starting point at that. Now, Alice, please.
Yeah, so one of the starting points that I think, where we should actually anchor a lot of our efforts is around talking about the fact that colonialism has devalued our beliefs, our traditions, our knowledge, and we need to deeply think about the systems within which we work. We may want to change so much, but if we change, if we only think about change in terms of bringing in new individuals, bringing in new tools, it may be so hard. We need to go back to the roots of the issue. What is the kind of knowledge that we are believing in, first of all, as leaders, women leaders, but then also as a community that is in many of the parts in the world that have been, hugely affected by this notion of colonization of global health. So if we try to decolonize the knowledge that we have, change the kind of thinking that we are seeing going on right now, then maybe we will be able to reach somewhere. Many of us in this part of the world, in Africa where I am, we have been devalued to an extent where we do not believe in ourselves. We are not proud of whom we are. We tend to think that our system, our cultures and values are pretty much inferior to the systems and cultures of elsewhere. We tend to think that any solution that has come in from Africa, for example, is inferior. And that is why we only look out for that has come in from the West. Until we get to that extent, to that moment where we are able to decolonize the kind of knowledge and thinking that we have, then we may not get so far in what we are thinking about. You could think about different women, for example, women or community health workers, or whomever in this region, for example. But if you think about them in the sense that, or if you think about us in the sense that if you think about us in a way that in order for us to be able to change this culture, then sorry, I lose my thought. Sorry, I'm so sorry about that. I'll hand over to Bridget, to Prof, and I'll get back. Thank you.
Thank you, Alice. I thought those were tremendous remarks and fully complete. So whatever you might have thought you forgot, I don't think you did, but we're looking forward to hearing more from you as well. And let's turn to Mareli now.
Thanks so much. And I'm going to again add a little bit onto what Alice has said. For me, I have basically got 3 words that I want to mitigate the whole challenge into. I know it's not that easy, and I'm going to say a little bit more about that, but I'm going to start with these 3 words. So from the global north, I think I've already mentioned awareness. So for me, that's number 1. That we become more and more aware. Each of the 5 of us has now highlighted a different area where we've experienced colonialism in health. Each of these areas need to be addressed. It can only be addressed if each one of us, but also everyone on this call and people the world over become more aware of these challenges. So that's the first word, awareness. The second word that I want to mention is that people should become, especially people from the global north, should become allies for people from the global south. So, and that's something that I've mentioned previously as well. Sometimes we are just, really getting fed up of asking for help the whole time. Sometimes we just have, we literally just need a hand that reaches out to us. So I really think that people from the global north should, in addition to a raised awareness, also become stronger allies for their partners from the global south. And then on the other side of the coin, because I think sometimes we forget the other side of the coin, for the people from the global south, for each of us, for each of the 5 of us, but also for other people from the global south, I want to say that we have to be adamant, and that comes back to the point that Alice has made, that sometimes we think that we're not good enough, but I think we have to be adamant that we are good enough, that there is not a real hierarchy of knowledge, that some people, that some things are better in the global north. Yes, we know that, but some things are better in the global south. We have local knowledge, we have local solutions, and we can build on that. And we have to be adamant that we also know very well what's the best for each of our communities and for each of our places. So for me, to be adamant, one can be adamant in different ways. I want to say that one has to be adamant respectfully, because I value respect and I value integrity. But it doesn't mean that we have to be shy and that we have to shirk away from the things that we are good at. So while I've said my 3 words, I also want to mention a few other more concrete examples. So for instance, the example that I've mentioned previously about papers, publishing papers with colleagues from the global north. I think there one really has to treat each other as partners. So if you go into a research collaboration right from the start, the partners from the global south they have to say their say, they have to put down some guidelines and say, this is our publishing guidelines, this is how we're going to do this. And then, stand on the guidelines and not be shy once the results are available for the research findings. Then say, you know what, we agreed that I am going to be the first author, or I'm going to be the corresponding author. And this is what is in our contract, and this is what we are going to do. So I think for the partners from the global north, instead of thinking of publishing papers as charity, rather think of this as a fair practice. The partners from the global south are just as well trained as the partners from the global north. It shouldn't be charity to have a partner from the global south on the same paper as a partner from the global north. It's just basic fairness. The other thing that I wanted to mention here was with regards to the hidden costs that I referred to previously. And I think there are quite a few things that one can do there, and quite a few of these things are already happening. So for instance, for international conferences, make sure that these are not in countries where people from Africa or people from other low and middle income countries cannot attend because of the reasons that I've previously mentioned. Make sure, and luckily we've seen that now during the pandemic, that there's a hybrid component, that if someone cannot attend, that they at least can attend online. Make sure that if there is a budget line for conference attendance, that the partners from the global south at least has autonomy and can decide which conference they want to attend, and whether they want to stay 1 extra day because they jet lag, because they can only fly economy class. And then the other thing is just build into the timeline that we actually every single time have to apply for visa applications. So if we know, for instance, we want to go for a conference and we have to submit an abstract, we have to know beforehand how long is that going to take to apply for a visa as well, because it doesn't really help if we get an abstract which is approved or accepted, but then we don't get a visa. And I just want to come back one more thing to the points that Bridget has made, specifically with regards to women. And I think for women who want to attend scientific conferences, everything becomes even more challenging, because most of the time we do have small children. What do we do with our small children? Can they travel with us? I know some of the funding mechanisms are nowadays including specific arrangements for children, so you can actually take your kids with you. But then what do you do? Do you carry your child the whole time with you at the conference? Is there a childcare facility? There should actually be a childcare facility, and that's just an additional aspect that women should think about when they go to scientific conferences. So there's a little bit of additional funding necessary for that. And we just have to start thinking out of the box and realize that as women, we can actually contribute as much as men, but our lives are a little bit more challenging, especially when we have small kids. So I'm going to leave it there for the moment and maybe have two sentences, last remarks right at the end.
Thank you very much. Those are excellent points and certainly things to keep in mind. There's inequalities by geography, by resource, by gender, and in many other areas. So let's turn now for last thoughts to Preethi and then Bridget.
I just want to add a couple of points to this very important discussion, and a lot of very good points have come out. One is definitely on the part that, when we talk about decolonization, it may be uncomfortable, and we do not want to start another process of alienation or exclusion. Rather, we want one of inclusion where people talk about it and talk about it. And that's something we hope to take forward when we 5 fellows are there in Harvard itself, to really be able to take this conversation further. Second, while we talk about decolonization, we kind of look at the past and its impact, the repercussions, the consequences that it has had. At the same time, we could be actually causing a new movement of colonization in one sense. Perhaps it's because of social media, but perhaps it's because of other ways. So that's also something to think about. We want to move forward away from certain practices to a more inclusive, but at the same time, we do not want to set up a new way of exclusion or infringing the rights or not listening to the voices of certain others. So that's my 2 bit. Thank you.
Thank you, Preethi. Bridget?
Yeah, my last thoughts, I think, as I've mentioned, that it would be helpful to have meaningful representation and participation of women, and certainly men and women from the Global South, but definitely also making room for women. And I think because of the way that the structures are, if you've only got 1% of women, you have to make deliberate choices to make sure that they're involved. And I think that, for example, I mentioned I'm part of Women in Global Health, and there's currently a move towards getting a steering committee, and there's blocks where it will be 1 person from Africa, 1 person from this region, 1 person from this region. And I think you have to be deliberate in your efforts to do some things like that, because otherwise, if there's no slot available, then it will all be filled by from 1 region, for example. So I think that in some of these instances, you have to be very deliberate about making sure that those slots are available for not only low-income countries, but also women. And I think that we know that these kind of decisions sometimes become tokenistic. So I think to really be able to make sure that when you have that position available or that slot available, that they're genuinely contributing. I think one of the challenges we see is that then you just have the slot for Bridget to be the LIC person, but she doesn't say anything or is not able to contribute, and her decisions and her contributions are sidelined. So I think it's one, making sure that those positions are available for women to be involved, especially from the organizations that are running global health or involved in global health, but then also making sure that when they contribute, that these things are not sidelined. And I'd also like to, just one last point, is to really look at global health in its diversity. I think it's fortunate we're all here speaking English, and most of us are Western trained or have some form of Western training, but the reality is that the majority of women who we want to represent are not going to be able to speak English or be on Zoom and things like that, and how to be involving of them. So even as ourselves as women leaders, I think it's important to have that diversity in mind, that it's not just a medical doctor or a nurse, that we really do bring on, can the traditional birth attendant be a board member of something huge, one of these governing bodies? She should be, because she understands. And I think those are the kind of changes we need to see. It's not just superficial, but it has to be practical, but also realistic and reflective of the reality of where these women are and who they are. Thanks.
Thank you, Bridget. Those are really powerful words, and they follow extraordinary interventions by the other lead fellows. We have just a couple of minutes left. I'd like to really thank the lead fellows first and ask if there are any questions. I know the chat has been active, but perhaps someone would like to ask a live question. Syra, please.
Yes. Hello, everyone. I just first want to say I am so grateful that this event was put on, and I think everyone spoke so eloquently, and I was just clapping the whole time. And I think it was really incredible to hear all these voices in the same space, and it's something that I think about very much. And I would like to ask, I'm a young researcher, really just getting started myself, but I am based in the US, but I also work in the humanitarian space. And what I have found is that as I'm building my career and as I'm looking to generally do research, I want to be able to reach out to many people. But I found that even in a simple Google search, what you keep seeing returned is large organizations. So even I was literally Googling Congolese organizations that have been involved in the Ebola response in the Congo. And WHO comes up, UN organizations come up, and the contact information, then of course you get higher ups and those who are, again, based in Geneva, et cetera. So I'm curious if there's any advice that you could share for someone like myself, really trying to, again, integrate this so much into my work. But these systems, as we were also discussing, aren't quite in place to support this.
Yes, that's right. Google ranks things by link analysis. So the more popular something is, the easier it is to find. And that excludes things that are not popular. But maybe one of the fellows would like to speak to that. Yeah, sure. Mareli, go ahead.
Thanks. That's a great question, and good luck with the start of your research career to start with. I think what I could suggest, if I may make a few suggestions, is to first start with the people that you know already and ask them if they have any contacts in these areas where you would like to work, because we are actually a global village. And I mean, if I can just speak for myself, I have networks going to Europe, to Taiwan, to India, to the rest of Africa, to the US, to the UK. So there might be someone who you're already familiar with at your institution who might have a good contact for somewhere else where you want to go. And the second thing that I want to mention is that many times research in these areas are also conducted by not necessarily huge organizations, but NGOs and other types of organizations who are also might be funded by international organizations, but they are local and they are NGOs or NPOs. So that's maybe an additional thing that you can look into. And then lastly, contact the universities directly. So at many of these universities, there are research centers or at least research groups. I'm not familiar with the Congo as such, but I can speak to most of the Southern African countries, and there are many universities with research groups. So those are the three things that I would look into.
Thank you, Mareli. I am afraid this brings us to our time. And I'd like to thank the fellows deeply for these interventions and underscore the multifaceted, multi-layered levels of colonial influence and the imperative to decolonize. That is a task that begins with self. As Alice was emphasizing, it begins with the way you think about the world. It begins with the way you prioritize things, the way you perceive information, who you think is an expert, what you think knowledge means. And in this case, where we work in health, the imperative of emphasizing individuals and their own primacy, the primacy of their languages, their cultures, the primacy of autonomy for their countries, those need to be top of mind. That can let us work on the systems that we've heard so much about. So please join me in thanking the lead fellows with a nice round of applause. And thank you everyone for coming.